Now it is my pleasure to introduce our first speaker, Dr. David Michael Harris has a PhD in neurophysiology. His research activities include, and listen to this, neuroscience, auditory physiology, otolaryngology, laser dentistry, photobiology, photodynamic therapy, medical lasers, robotics, and optoelectronics. Lecturer and author of numerous peer-reviewed journal articles, Dr. Harris was the lead researcher on laser procedure for reducing perio pockets. Please give a warm Academy welcome to David Michael Harris.
Good morning, everybody. Let me tell you about my real financial interest in this. I've been a consultant to the dental laser industry for 20 years, and I've made a living. 2 wives, 2 houses, 3 kids through college, a bunch of really nice cars. So I've made an income as a consultant to the industry, but I've never been an employee of a company. I've recently, though, hooked up with a company called Uvicide, and we're developing a product I call the antimicrobial laser, and I'll talk a little bit about that at the end of the talk. So I do have a financial interest in that, but it's based on 20 years of scientific investigation, and I think it's a good idea. So let me continue with what I'm going to talk about first. Now, the title of my talk was After 20 Years of Laser Dentistry, so what has emerged? And I changed the title. I'm going to talk to you about biostimulation, photodynamic therapy, LANAP, and targeting periodontal pathogens with lasers. I'm currently a senior research fellow in otolaryngology at the University of Washington, where I'm doing brain research. But I'm still on the side working on dental laser applications. Here's my email address. I hope you would write it down. If you have any questions or you want to correspond about some of the scientific data I'm going to present, I would appreciate if you send me an email. I'd be glad. I usually respond to emails better than phone calls. What I have here on the cover page is a couple of gingival epithelial cells, which we grew in culture, and we incubated those with Porphyromonas gingivalis. And this shows immunohistofluorescence of that preparation, and you can see that the PG in red have invaded these GECs, and they cluster around the nuclei of the cells, where they inject their own DNA into the nucleus. They inhibit apoptosis, so the cells can't die even if they want to. And they command the molecular machinery of the cell to their own purposes. These one of the strategies of these nasty little periodontal pathogens, and it's shown pretty clearly in this illustration. And I'll talk a little more about this later. Let's go forward. The first thing I want to mention, first of all, I heard that you people are very interested in science and basic science, and I'm going to give you a lot of technical information. I hope that I don't overwhelm you with this, and that's why I left my email up there if you have any questions you want to get a hold of me. This first topic I'd like to talk about is photochemistry. This is one of the low-level laser effects. You take radiant energy and light, and you transform it into chemical potential energy. This is a non-thermal effect. And we're familiar with the process of photochemistry and vision. And here the molecule that absorbs light is rhodopsin in the outer segments of the visual cells. Rhodopsin is a derivative of vitamin D. It's got a little vitamin A. It's got a little kink in its side chain, so it's set like a mousetrap. And when it absorbs a photon, that conformation of the molecule changes, and that conformational change sets off a cascade of events which leads to formation of action potentials in the optic nerve. In photosynthesis, you have radiant energy is absorbed by the chloroplasts in the cells, and that's transferred through a chemical process into an increase in ATP for the cells, so that plant cells do what plant cells need to do with that energy. Photodynamic therapy is also a photochemical process. I'll talk about PDT later in the lecture. Here with the chromophore, the light-absorbing molecule is a drug that we inject systemically or sometimes topically into a tumor cell or a tumor, and the photofrin, which is the drug, absorbs a molecule or absorbs a photon and starts a chain of chemical reactions which destroys the tumor. And I want to talk about biostimulation, also known as low-level laser therapy. This is also a photochemical reaction. Unfortunately, we don't know exactly what the chromophore is or what the molecule is, and the science in terms of photostimulation, biostimulation, is not that great. So we don't have the basic science behind this procedure. However, the procedure is widespread at this time. Let me go back, I'll give you a little historical perspective on biostimulation. About 3 billion years ago, an event occurred in the evolution of cells. And this was a photosynthetic bacteria that found its way into nucleated cells and became the energy-producing organelle within the cytoplasm of the cell, which we know as mitochondria. So mitochondria within animal cells is actually a primitive photosynthetic bacterium. And if you look at electron transport in mitochondria, you can see in the chemical reactions there's a section of molecules in the membrane which resemble the photosynthesis in this bacteria. There have been a lot of other chemical reactions added on during the evolutionary process, but essentially what can occur within mitochondria is that these cytochromes not only can metabolize glucose, they can absorb photons, start this chain reaction, pump protons across the membrane, and this proton pump then leads to the generation of ATP from ADP. So the mitochondria within cells are capable of photosynthesis, and I believe this is the basis of biostimulation. Here's kind of how it works in a cartoon. Oh, this is, I got to wave my hands around, and you'll notice that this is a very colorful cartoon, so I'm giving you a story rather than data. The mitochondria within the cell can absorb the photons, and it can generate synthesis of ATP, whereas the normal metabolic machinery of this diabetic cell is compromised due to the problem with the glucose permease. Thus, we can increase the metabolism of these, this is shown here, a fibroblast, by irradiating it with light. Now, in the olden days, billions of years ago, these cells were on the surface and could absorb light, but now they're deep within a multicellular organism and they're no longer capable of photosynthesis because they don't have access to light. However, the advent of high-intensity light sources such as lasers has provided an opportunity to get light into these cells and increase their metabolism. This is another cartoon that shows how we have a set of cells which have low metabolic rate due to some disease process. We can supercharge these cells by putting light in, bring their activity back up to a normal level, and return the tissue to a homeostatic level, function. This is the problem with laser biostimulation. There's a tremendous parameter space with the laser, wavelength and pulse duration and timing parameters, spot size, and so forth. And that when they were first introduced into the medical arena back in the 70s, it was thought that they did some magical process. And I'll tell you, lasers are probably the strongest placebo device ever devised by man. There's about a 40% placebo effect using lasers. And there's also the white coat effect and just being in a study that makes people better and so forth. Pain, ulcers. I've seen schizophrenia, the treatment for impotence using low-level laser therapy. Just about everything you can think of is claimed as being an effective treatment using the laser. But the real applications of low-level laser therapy, BioStim, are really yet to be revealed. The FDA has approved low-level laser therapy for carpal tunnel syndrome. General Motors ran a huge study with 1,200 patients and showed an effect on pain. And with those data, they finally got their approval. The biostimulation industry has been trying to get approvals through the FDA for about 25 years. And finally, General Motors managed to get this one approval. And now there are a lot of piggybacks on that approval. And there are a lot of these low-level laser therapy devices out in the marketplace. I think that is very effective for analgesia. It shows there's some good data for accelerated wound healing. We're doing a treatment now using lasers for toenail fungus, and we find that the light irradiation with the laser makes these nails grow faster. So we have two toenails in the group. Well, one is treated and one's not treated, and the treated toenails are growing twice as fast as the untreated toenail. So I think there's something to do with accelerating the healing process or the metabolism of the irradiated site. But there's still no real convincing clinical trials in dentistry that I know of. And if someone knows of such a trial they'd like to tell me, I'd be glad to look at the paper. But stay tuned. The science is getting better. There's some really good researchers now working in this area, and I think that within the next couple of years, we'll see what is the real biological basis for BioStim. Here's my website, biomedicalconsultants.com. There's an article in there that I wrote in 80-something that describes the scientific basis for BioStim. And there are a bunch of other articles on dental lasers that I'd like you to take a look at that are available download from that website. I had a bunch of articles I wanted to hand out, but I got in a little too late, and I'm sorry the section in my book is blank. But you can pick up these articles at the website. So moving from BioStim, I'd like to show you the first clinical neodymium YAG laser. This is a mobile neodymium YAG. And notice the handheld, flexible, articulated arm looks kind of like a bazooka. And a lot of concern about safety with an explosion-resistant partition, flashing lights all the way around the room, laser-proof window, and so forth. We weren't sure what was going to happen when we turned these lasers on back in the middle 70s, early 80s. Give you some idea of the concerns for safety. And now I'd like to pause for a brief lesson on laser safety. I always need a laugh or two to keep. We started the Wensky Laser Center about 1987 at Ravenswood Hospital here in Chicago. And at that time, I was Director of Research Otolaryngology out on Taylor Street at the Eye and Ear Infirmary. And I became a consultant to Ravenswood, and we put together this laser center. And the idea was that we could bring physicians in to use the equipment so they wouldn't have to purchase it, and they could use the hospital facilities. And one of the devices that we had was an early ND-YAG laser, this one that I call the washing machine. It's a huge thing. It was a 100-watt continuous wave ND-YAG. It was fiber optic delivery, so the gastroenterologists really liked this device because they could get it into through their endoscopes and coagulate bleeding ulcers and so forth. Here I actually have hold of the handpiece, and we're treating a keloid, doing an experiment to see if the laser energy would reduce the growth of these keloids. It didn't work, but it was a research project. For general surgery, surgical laser technology came out with a contact tip that they put on the end of the fiber. And the contact tip actually absorbed the energy coming out of the fiber and heated up the tip. So the way that this surgical device was used, it was a red-hot tip that would be drawn across the tissue and make an incision. We found there was just way too much collateral damage with such a device. And besides, this laser was replaced by the diode laser, which was caused less thermal damage and was certainly less expensive. And since that time, there's been a plethora of these diode lasers. Almost every company has come out with a diode. I think there are about 10 different iterations of this device out in the market. I'll talk a little bit about the diode laser and its effect on tissue. How many people, by the way, have lasers in their practice? Whoa, look at all that. How many are diode lasers? And ND-YAG lasers? And how about something else, like CO2, this and that? So we got a lot of laser users. So this will be useful information. Continuous lasers, not pulse, but continuous lasers can cause extensive thermal damage. This is an experiment we did on rat liver. And what you see here are a row of lesions made with an argon laser, and this is with that pulsed ND-YAG, or with the continuous ND-YAG laser I showed you in the previous slide. This is a 1/10 of a second duration burn at 30 watts, and this is up to 2 seconds at 30 watts for both laser systems. And so this is what we saw initially making our little burns in the rat liver. And then we sewed the rat up, and we sent him home, gave him cab fare to come back. And in 2 days, we opened him up again, and this is what we saw. Much greater extent of damage than we saw immediately. So what you see is not what you get with these continuous lasers. There's a great deal of thermal necrosis that continues over time. If you have a diode laser, you might see this kind of effect. Intraoperatively, you might see a little line of white necrotic tissue around the incision. And if you get your patients back in a day or 2 days and look at it, you'll see there's more extensive thermal damage than you saw originally. This shows you how deep these lesions made in the tissue. And, I'm supposed to use this slide. So this is an interesting little graph. It shows the depth of penetration of light of different wavelengths into soft tissue, like skin. And here's the argon laser in the visible green. Diode laser is right here. The deepest penetration is right here where the ND-YAG has its output at 1064 nanometers. And very shallow penetration for the carbon dioxide laser and for the erbium laser because they're absorbed strongly by the water in the tissue. Now, pulsing, we've learned, provides what I call thermal precision. This is an incision made in an orange with a continuous laser, and you can see the amount of char that was generated. Same wattage, but now we have a pulse laser, and you can see that that char is eliminated by pulsing because there's less spread of thermal damage to the surrounding tissue. This is shown in this histology. Here's a 2 microsecond pulse, 2 millionths of a second, and you can see a thin zone of coagulated tissue about 50 microns deep. We increase the pulse duration to 600 microseconds. This zone of thermal damage increases. By the time you get up to 50 milliseconds, you have a fairly extensive zone of damage, given that all the other parameters are the same amount of energy deposited into the tissue. This is an incision made with a diode laser, and you can see about the same amount of thermal damage that we got with the long pulse on the CO2. Now, everybody who raised their hand, they have a diode laser. You must read this article by Eric Bornstein. And I asked the people at the Millennium booth if they, I got my copy from them, a PDF version. Eric is the first person I've seen who's actually looked at the diode and seen how it operates. It's a completely different process than the ND-YAG laser. If you have a diode, you know that one of the things they tell you to do is initiate the tip on a piece of carbon paper. And what this does is it makes the tip then absorb the light, and the tip gets hot. And just like the old contact tips of the ND-YAG, you're just cutting with a hot tip. You could take a a paper clip and put it in a Bunsen burner and make a cut with that and get the same effect. You need to read this article to understand what a diode is. Once you understand it, then it's a useful tool. I don't want to say that the diode laser is not any good. I'd say that any laser is better than no laser. And the diode laser has some unique properties that allow you to do various procedures, but you need to understand the biophysics behind what you're doing. So one of my collaborators from Ravenswood was Harvey Wigdor, and those of you in Chicago probably know Harvey. Harvey and I did this experiment with an ophthalmic pulsed YAG used for a posterior capsulotomy, tried to drill a hole in enamel. And so that was my first foray into dental lasers back in 1987. Terry Myers in 1988 started messing around with a pulsed YAG in his private practice and found that it was really an excellent tool for treating periodontitis. And from that emerged this procedure of LANAP, which I'll talk about. But right now I want to talk about this last paper, which is I did with a study. We did a multi-center trial at UCSF, the University of Pacific, and at Baylor Dental School in Texas. And we looked at the selective ablation of surface enamel caries with a pulsed YAG. When I joined American Dental Technologies as a consultant, they were trying to get their laser approved through the FDA for drilling enamel, for drilling dentin. They wanted to make a dental drill with the pulsed YAG. And I looked at the physics and I looked at their data along with the FDA, and I said, well, this is not the right indication for this device. It's good for ablating pigmented soft tissue. And so we changed the structure of the study to selective removal of enamel caries, and rather than target the enamel, we targeted the caries. Here's an example of what it looks like. Here's a decay on some enamel. This is an in vitro study, irradiated with the laser. There's no photosensitizer that was added. This is just the pigment that's generated within the bacteria, and there's a chemical reaction that also pigments the tissue. And it absorbs selectively that laser energy, and we can remove it selectively. And then after acid etching and a little bit of scraping, we end up with a preparation that looks like this. Now, the interesting thing about removing this surface enamel caries is that you see a little light flash and you hear a little pop, 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 pop as you remove it. And once it's gone, the flash is gone and the sound is gone. So it's self-limiting. And in our clinical trial, we found that we compared the laser removal of surface caries with the dental drill. We found that fewer of the preparations in the laser went into dentin than in the drill group. What this meant was that the dentist was chasing the pigment down into the dentin, and this was actually sound dentin that they were removing. But the laser removed the caries selectively, so we had fewer preparations that penetrated dentin. Now, when we got approval for this indication, I thought it was going to be the bee's knees and that everybody was going to go out and do it, but it didn't seem to catch on. So this is not one of those indications which has turned out to be very useful. If you have the laser, it's great for kids. You don't need anesthesia. If the caries doesn't penetrate down into the fissures, it's good for just the surface. But if you have to go down and chase it, you've got to use the drill. I hate lasers. So another thing that we did with American Dental Technologies is we ran a clinical trial for laser sulcular debridement. And we wanted to get approval from the FDA for putting the fiber in the pocket. At that time, in the early 90s, it was not an approved indication. So we ran a clinical trial at Marburg in Germany and kind of screwed up on that, but at least we learned what we were doing. And then we ran a really good trial at the University of Texas with James Melinig and Mary Beth Neal. And we got some good data. We submitted the data to the FDA, And we got this indication, sulcular debridement, removal of diseased or inflamed soft tissue in the periodontal pocket to improve these clinical indices that we measured. The clinical gingival index, the gingival bleeding index, probing depth was improved, attachment loss was minimal, and tooth mobility was improved. So we got that indication from the FDA. We ran a third study actually at Louisville with Dr. Greenwell, and we got essentially the same results. Then American Dental Technologies kind of faded away, folded, and I was contacted by Millennium to get their FDA clearance. And with Millennium Dental Technologies, we ran, I reviewed private practice data, and we got Ray Yuckna to run a study down at Louisiana, at LSU, and Ray ran a extracted tooth study where he did the procedure around 6 teeth, and then he extracted the teeth and looked at it histologically. The data were excellent, although he's had trouble getting it published up until recently. And we got approval from FDA showing them mostly raised data for cementum-mediated periodontal ligament new attachment to the root surface. And this is in the absence of long junctional epithelium. And again, there's an article that I want you to read. It's this Yuckna and Carr article. It's available out there at the Millennium booth. Histologic evaluation of the Nd:YAG laser-assisted new attachment. I'm going to show you some of the data from this study. Harris, Gregg, McCarthy, Colby, and Tilt. These are 3 private practices where I went in, collected data, and looked at the outcomes. So Bob, Gregg, and Del McCarthy used the procedure that American Dental Technologies studied scientifically in a controlled clinical trial, and they adapted it to their own clinical practice. Bob's got an excellent background in medicine, and so he added a few things to make it medically sound procedure. And the procedure is called LANAP, Laser-Assisted New Attachment Procedure. And it's a 6 or so step process where first you measure the probing depths, then you do 1 pass with the laser to remove the diseased epithelium. After that, you do your scaling and planing to remove the calculus. You do a 2nd pass with the laser with slightly different parameters. You seal that gum back up to the root surface, and then you do occlusal adjustment. Occlusal adjustment is a very important aspect of this procedure that improves the success. And what happens during the first pass when you remove the diseased epithelium? This is an example of the histology, and what you can see are the little rete pegs. There's a little cartoon running on the Millennium booth, but this is what it looks like histologically. You selectively remove the epithelium, leaving the connective tissue intact. And how is it that it's selective in that removal? Because it's pulse laser, it's a 100 microsecond pulse, there's negligible thermal damage, and it's a surgical technique that you need to learn and become good at. Well, I've studied this wrinkle removal, and scientifically what we've seen with removing the epithelium from the skin is that when you apply these short pulses, there's an increase in energy density right at that interface between the epidermis and the dermis. And that's caused by reflection at that junction, also by backscattering at that junction. So you have a much higher energy density right at that interface between epithelium, which is mainly intracellular water, and the dermal layer, which is mainly extracellular water. And it pops the epithelium off. And you can see that in this illustration here, a nice removal of the epithelium with about 15 microns of thermal damage underneath. And I think that's what's happening on pass 1 of the LANAP procedure. You're selectively popping off that epithelium and removing the diseased tissue, and then it regenerates. So the results of the PASS 1 are that you have removal of the epithelium, but you've also photocoagulated the pigmented bacteria that reside in the pocket. You've affected hemostasis. You've kind of opened up the pocket and improved visualization. There's no data, but I suspect that there are reduced bacteremias following this procedure. When you do your scaling and plating, that calculus is now disinfected, and it doesn't get into the bloodstream. So that there are several advantages to this PASS 1, doing it prior to the scaling and planing. And one of them, of course, is improved visualization, and the other one is control of bleeding. Then they do PASS 2 after scaling and planing, and this is with a longer pulse. Remember, the longer pulses provide more thermal damage, and what this does is it coagulates the remaining blood in the pocket and makes kind of a fibrin glue. And when you push that gingiva back up against the root surface, there's a bit of a gluing action that holds it in place. And sometimes people use a, what is it called, PerioGuard or something that holds that tissue in place while it heals. Well, what happens after LANAP is really quite miraculous. This is a bone density scan of a patient. Here's pre-treatment. You can see this large defect in the anteriors. 9 months post-treatment, you see this bone starting to regenerate, and by 14 months you have a fairly good regeneration. And this actually shows you the density of the bone as it progresses over this time period. Here's another example. This spongy-like inflamed bone is seen pre-treatment, and you can see here the probing depths, 7s and a 9 and an 8 and so forth, that are reduced post-treatment down to 3s and 4s, and here's 1 6. So probing depths are reduced. Bone seems to be regenerated. This is the results of Ray's study, and as I mentioned, you can pick up the entire publication at the Millennium booth. The bottom line is right here. 6 teeth were treated with LANAP. 6 teeth were treated with scaling and planing alone, or actually pockets, not teeth. And 6 out of 6 showed new cementum in the laser treatment group. 1 out of 6 in the scaling. New bone in 4 out of 6 of the laser treatment, and only 2 out of 6 in the scaling and planing group. And new connective tissue attachment in all 6 of those pockets as well. So that was Ray's study, but prior to that I had done this evaluation of the data from clinical practices. Bob said, I've got some great results and I want you to look at it. And I said, well, I'm going to have to select the patients, and you can't do the selection for me. So I dug through about 200 patients, and my criteria for selection to inclusion in this study were 21 patients who had complete records, and that was just my selection criteria, not anything to do with the outcome. Lee Colby had just been trained by Bob and Del, so we took his first 18 patients sequentially and put them in the study. And Lloyd Tilde out in Ogden is a periodontist who was about to retire until he got his laser, and then he got so excited, it was so much fun, that he went back to work for a couple more years. And he's still out there now playing with his laser. And again, I went to Lloyd's office, and I selected the patients based on complete data. So we had 65 patients that were treated with LANAP. There were no controls, so I was just looking at the outcome. They ranged in age about in their 50s, and the mean pocket depths for these patients were from 4 to 5 millimeters. Here is one tooth. This is a 16 millimeter pocket. I guess it went up into the sinus or something. And this is the pocket depth measured at 3 months, down to 4, and it's stable out to 27 months. And if you look at all the data, you see that these very deep pockets respond very nicely. Here's a negative result, but that's within the variance. And I think this is due to probing at 3 months. You have to let this tissue heal. And if you go in there and probe, it's still a little bit friable. You don't want to do that. You want to look at 6 months when healing seems to have occurred. And then it's stable out here to 3 years on all these patients. And these are thousands of pockets that we looked at. So what I see is a healing phase over the first 6 to 12 months, and then long-term stability of this treatment out to 3 years. We now have data that goes out much farther, and I'm trying to convince Millennium to let me look at that. And actually, I'd like to design a study that we could go out 20 or 30 years and look at how well these patients do in the long term. Deeper pockets respond better than shallow pockets, and even when you look at percent reduction, you still see deeper pockets respond better than shallow pockets. Here's LANAP data. This is the mean pocket depth reduction. In other words, this is how much the pocket has been reduced following the procedure. And this is the pre-treatment probe depth. And what I've shown here is just the variance and the number of pockets that we have in each category. Here's another one of those 19 millimeter pockets. I don't know what the hell that means. But the way to read this graph is if you have like a 10 millimeter pocket and you get 7 millimeters of pocket depth reduction down to 3, that's good. That's what I call return to health. So this line represents reduction to 3 millimeters. And you can see that the LANAP procedure does a pretty good job of reducing these pocket depths, approaching this healthy level. Here are data from scaling and root planing. The data only go out to like 7 millimeter pockets. They usually don't look at these very deep pockets. And to compare these three, it looks something like this. This is what we'd like to see. This is what LANAP does. This is scaling and root planing. And LANAP, of course, is effective on the very deep pockets. You can do some very heroic procedures. In fact, I've made money doing laser dentistry, and I went to the dentist after 3 years. I moved and, you know, blah, blah, blah. And he says, you got a 9 millimeter pocket here, right here. We're going to have to yank that puppy. And I said, well, I got a better idea. So I decided to put my mouth where my money was. And I went to Millennium. I said, who do you have out here that does this procedure where I live now in Seattle? And they gave me the name of a doc. And I went and had LANAP done on just one side. I haven't been back for the other side yet. You know, I get busy, and my insurance lapsed for the year. The procedure was pretty much painless, and I was uncomfortable for a day. 2 days after the procedure, I didn't notice that I had had it done. And the pocket's gone. It's now no more problem, no more infection, no more pain. I just have to get back, have the other side done. So wait, let me go back one. How do we close this gap? LANAP is good, but we're still not completely 100% effective. And it means there's still room for research, still room for improvement of these procedures. And one of the possibilities is what's called photodynamic therapy. And I've seen a lot of papers now in the literature applying PDT to treatment of periodontitis. The idea is to photosensitize these bacteria and then irradiate them with light. We were doing PDT at the Wensky Laser Center early on, something that was developed by this guy, Tom Doherty. The drug is a dihematoporphyrin ether that's injected systemically. It localizes in the tumor. And then we irradiated it with this dye laser, argon pump dye laser, which was back then a $30,000 instrument, very expensive in the 80s. And you also had to hire an engineer to live in the room and tweak the thing constantly. Here's how PDT works. In an animal model, we implant a tumor, we inject the drug intravenously, and you can either wait for the drug to localize in the tissue. You can irradiate it with blue light from a Woods lamp, and the drug fluoresces, so you can see its localization. and identify occult tumors. Or you can irradiate it with red light, which penetrates deeply into the tissue and causes this photochemical reaction, and you end up with a happy little mouse. Here's the chemical reaction. HPD is the original form, hematoporphin derivative. It's now dihematoporphin ether, absorbs a photon. The molecule is excited to a higher energy state. It can decay spontaneously and emit a fluorescent photon, which you see as this fluorescence in the tumor, or it can couple that energy to molecular oxygen, forming singlet oxygen, which then oxidizes the host tissue. Here's a squamous cell carcinoma at the angle of the jaw, and you can see how localized the drug is to the tumor. We insert the fiber right into the tumor and irradiate from the inside out, so we get light irradiation throughout the tissue, and you can see how really selective the necrosis is of the tumor following the treatment. We did some studies in otolaryngology looking at photosensitization of oral squamous cell carcinoma. And here is pretreatment, and then after the injection, you can see that this tumor on the base of the oral cavity has been fluoresced. I can't find my result slide for this one. But you can see also that the plaque is fluorescing. It means that there's probably some bacteria in here which are sensitizable, if that's a word. So the concept with PDT for treating periodontal pathogens is that the pathogens selectively take up the methylene blue or toluene blue, which can be applied with a brush to the pocket. And when these bacteria are then so sensitized, we irradiate it with light, and we can selectively destroy the bacteria after the dye has been rinsed from the mouth, from the normal tissue. But there are problems with this procedure. First of all, drug delivery. A lot of these bacteria reside in what I call privileged sites and are not accessible by chemical antibiotics, so they're also not accessible by the photosensitizer. It's an expensive procedure, and it's a very complex procedure that may not work too well in the dental office. But lasers can destroy bacteria selectively without a photosensitizer. This shows Porphyromonas gingivalis grown in culture. This white stuff is a contaminant in the culture. And these are 1 millimeter size spots, pulses from a pulsed Nd:YAG laser. And you can see that these bacteria are destroyed without any sensitization. You can also see kind of a flat bottom on this crater, which means that the underlying blood agar on which they were growing was unaffected by the laser energy. So the bacteria were selectively photocoagulated by this single pulse from an Nd:YAG. And this is the device I was talking about that we're developing now. I call it the antimicrobial laser, or another way of thinking of it is PDT without a drug. Because rather than rely on an exogenous photosensitizer like photofrin, we rely on what's called the endogenous chromophore, whatever the pigment is within these bacteria that's absorbing the light. So we've done experiments with pulsed Nd:YAG laser, and this is an impulse laser, basically the same laser as the Millennium laser out there, the Periolase, except it has fewer bells and whistles. It's just kind of a stripped-down version. And notice that the pulse duration here is 100 microseconds, 100 millionths of a second. And compared it to a continuous wave diode laser. Now, to make the comparison, I had to gate this laser, make pulses, and I did that by putting a timer in the circuit of the foot pedal. So when you hit the foot pedal, you just get a 100 millisecond pulse out of the laser. And this is what that pulse looks like. And so bear in mind that there's a difference in these experiments between both the wavelength, the Nd:YAG is 1064 nanometers, and the diode laser was 820 nanometers, so it was farther to the red, or closer to the visible, but also a 1,000-fold difference in terms of pulse duration. We very carefully calibrate our laser beam. And whenever you read any laser literature, take a look at how carefully the energy was calibrated. It's a good sign of how good the science is within that article. And from that calibration generated this function, which shows us the peak energy density, how hot it is right here in the center, versus the target distance. And you know there's an inverse square law. This beam coming out of the end of the fiber is diverging. And so as you move the spot away from the tissue, the spot gets bigger, the energy density goes down as the inverse square of the distance. So this is the function for energy density for the Nd:YAG and for the diode that we used in these experiments. We grow Porphyromonas gingivalis in culture, anaerobic culture, and then we put the plate under a laser beam right here held in a stepper motor, and we can adjust that distance with 1 micron steps and very carefully adjust the energy density. And then we deliver a single pulse and look at the effect on the bacteria. So we start like this, and we hit a pulse and nothing happens, and we lower it, another pulse, move to another spot, another pulse, another spot. And finally, when we get to a certain energy density, we see a little puff of smoke. And that little puff of smoke indicates that we are now vaporizing the bacteria. And by doing this procedure over and over again, we end up with what I call the ablation threshold. There's some energy density which is just at the threshold for destruction of the bacteria. Here's what it looks like. 1 pulse. This is a superthreshold pulse. And pow, you see a big puff of smoke. And here's the PG in culture. It's about a 55 micron thick bacterium culture that's sitting on the blood agar. So I borrowed from the drug industry this idea of the therapeutic index. A toxic dose is a drug concentration that's toxic to normal tissue. And a therapeutic dose is the concentration that's toxic to the target pathogen. And the ratio between these two is a therapeutic index. So a high index means that you have a safety margin where you can destroy the pathogen without destroying the host. And here's what it looks like with the laser. Here's ablation, amount of ablation. And you see there's a little threshold for the ablation of the pathogen here at some irradiance. And you can increase that dose and still destroy the pathogen until you get to a certain level where you're starting to destroy the host tissue, for example, dentin. And at this is the ablation threshold for example, dentin. And then this area is the toxic dose. And you see that in this zone right here is the therapeutic dose where we're not destroying the host tissue. This is what it looks like on culture. Here's a series of pulsed Nd:YAG burns of various energy densities going down. Somewhere below 53 joules per centimeter squared, there's no effect. So the threshold's right around here at about 50. With the diode, same thing goes down, and the threshold here is about 100. This is a very important slide. This is an opportunity to make a quantitative comparison between different lasers and different parameters based on the clinical outcome. And these are the energy densities. I got to keep doing this one. These are the energy densities that are generated ablation thresholds for the blood agar, which is our model for soft tissue. And at 1,400 joules per centimeter squared, we could still not see an effect on the blood agar with the YAG, but the diode would destroy the agar at 148. Root dentin, these are the values, 300 and 250. For Porphyromonas gingivalis, 48 was the ablation threshold for a single pulse. And there's certain things we could do to tweak that pulse and get that threshold down to 20 joules per centimeter squared. For the diode, it's 96. And when you do these ratios, the soft tissue therapeutic index for soft tissue is about 30 for the Nd:YAG. And with our manipulation, we can get it up to 70. Whereas for the diode, the therapeutic index is 1.5. A guy named Kofelt did the right experiment, but he used the wrong laser and he used the wrong bug. But he did the right experiment. And because the CO2 is absorbed by water, the bacteria and the tissue have the same absorption, same ablation threshold, so you get a therapeutic index of 1 when you treat soft tissue with the CO2. Yes, sir. What an excellent idea. I have my best people working on that. Well, I did, because you just March 3rd. Can I talk to you after the... Where's your practice? Oh, okay. Well, let's talk. Yeah, we're developing the antimicrobial laser for a preventative procedure. So when you put the fiber in the pocket, the laser energy not only kills things on the surface, but it penetrates a certain depth into the dentin. And within that depth, you have a zone of energy densities that look kind of like this. So there is a certain boundary of energy densities. Within that zone, you're killing bacteria. Outside that zone, you're not. And because we measured it at 48 joules per centimeter squared, we can measure the light penetration into dentin and look at how deeply we can kill bacteria. So how do we do that? We do this thing called a Monte Carlo simulation. If you launch a photon into tissue, it takes this random walk through the tissue, do the very high scattering like this, and finally it's absorbed at some point here. And we use a computer to simulate this. And in each little cell, we have all the parameters of tissue optics. So we launch a photon and we see where it ends up. Then we launch another photon, see where it ends up. We do this 1,000,000 times, and we end up with a distribution of energy and light. If you go out to the Museum of Science and Industry, they have this thing. I used to cut school in 8th grade and go down to the museum. They drop a ping pong ball, boing, 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 into this great big plexiglass thing, and it goes boing, 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 and lands in bins, and you drop 10,000 ping pong balls, and they end up with a very nice Gaussian distribution at the bottom of the thing. That's a Monte Carlo simulation. So we did a Monte Carlo simulation of a 200 millijoule pulse into a 1 millimeter spot, and that's if you hold the optical fiber here like 3 millimeters from the surface. Now this is not what you would do clinically, it's just for the simulation. And when we do our simulation, we find that here's the zone of 48 joules per centimeter squared or greater, and this is 20 joules per centimeter squared or greater, goes down 800 microns into the dentin. And this is with a 200 millijoule pulse. And there are things we can do to increase this depth up to 1.5 millimeters. Now I thank Ray Yuckna for this slide. It shows a privileged site. Here bacteria is still residing in this defect in the dentin following scaling and planing. Here's another place where you can't get at these bacteria with antibiotics or with the immune system, which is their strategy for going intracellular. Another bacterium that does this is Actinomycin acetaminopatens, which also invades cells and resides intracellular. And by the way, it has a similar ablation threshold as Porphyromonas gingivalis. Now I'd like to show you this experiment. We took slabs of dentin, and we're going to irradiate cultures through the dentin and try and ablate the culture. And this was an extremely difficult experiment to do, to scrape the stuff off the bottom of the dentin and trying to assay these cultures. So I invented what I call dotacules, which are a model for a bacterial colony. And I make dotacules with an inkjet printer, a 4-point font, and I make a series of these little dots. And the ink has a very similar absorption characteristics as pigmented bacteria, as PG. And I make those uniform dots, and I have my fiber on a motor stage so I can position it over any dot without actually seeing the dot. And then we lay this slab of dentin down on top, and I cut these dentin various thicknesses and irradiate each dot through the dentin. And you can see, after you turn the dentin over, the explosion of that pigment has stained the bottom of the dentin, and here they're removed. Then I take and scan these dots into the computer, and I use Photoshop to look at the density. And here's an example from Photoshop of a bladed doticule, and you see the amount of pigment here as it's in the gray, and here's an unirradiated one down in the black. And this is a measure then of how much of that pigment has been removed. And this is also a measure called reflectance, which is the opposite then of absorption. So this is the reflectance of these doticules. This is the amount of pigment removed as a function of the radiant exposure. There's a threshold right here. And then as the energy goes up, you remove more and more, and finally you remove all of it at this level. This is with no dentin over it. This is through 3/4 of a millimeter of dentin. Here is a millimeter thick slab of dentin, and this is 1.5 millimeters of dentin. From these experiments, we get a very good idea of what the optical properties of the dentin are like, what its transmission is like, and we've demonstrated that we can destroy these pigmented doticules through the dentin. It's not exactly the experiment I wanted to do with the bugs, but it's a good scientific study. Notice at the bottom that we saw in this dentin 3 types. We have this clear stuff, we have this milky stuff, and this yellow stuff. And the ablation of the clear and the milky are about the same, but this yellow stuff seems to have less transmission of light. In other words, it's harder to get light through the yellow to ablate the doticules underneath the yellow dentin. And this yellow dentin is actually secondary dentin that surrounds the nerve canal and the pulp chamber. So in some regard, it acts as a shield or protective of the vital tissues for this wavelength of light. Now, this final experiment, I thank Dr. Jorgen Slotz. I'd like to thank Dr. Peter Reckman and Dr. Doug Dietrich, 3 periodontists who are not friendly to the laser industry, who said, well, this treatment doesn't work in vivo because these bacteria aren't always pigmented, and it depends on the availability of hemoglobin. So I said, okay. And we raised Porphyromonas gingivalis in different concentrations of hemin, and here you can see the results of that. 0.5 micrograms per milliliter hemin, and you get this very pale PG, and at a high concentration, 15 milligrams, you get pretty dark. So it's true. The availability of hemin affects the visual pigmentation of these bacteria. But we're irradiating in the invisible portion of the infrared. These are spectra of these 5 specimens, and you can see there is a very good relationship between the amount of absorption in the visible, but here out in the infrared, there is essentially no difference. So the absorption at 1064 is not related to the visual pigmentation. So the conclusion is that these can be targeted by the pulsed laser whether or not the bacteria have access to hemoglobin. The clinical significance of all this bacterial reduction is that for laser sulcal debridement and other dental treatments, the 100 microsecond pulsed YAG can selectively destroy pigmented pathogens to a depth of 1.5 millimeters below the dentin surface. And we can access bacteria that are in privileged sites, and we can access bacteria that reside intracellular. Future work, we're doing some soft tissue simulations. I know this is my last slide. I think that the penetration depth in soft tissue is something like 5 millimeters, much deeper than in dentin. We're looking at endodontic applications, and we're treating other infections outside of the dental arena. I've had many collaborators, and here's just a list of some of the people that have been working on these research projects over the last several years, and some of the institutions where we've done some of this research. And I thank you very much for your attention.